Thank you for your interest in our poster. We present to you a case series of 3 patients with COVID-19 who were found to have pneumomediastinum during their hospital stay. All 3 of these patients were admitted as inpatients to Henry Ford Hospital, Detroit. Our first case is a 70-year-old male patient who was admitted for hypoxia and encephalopathy, requiring immediate intubation on presentation. He tested positive for SARS-CoV-2. A CT test on admission showed acute pulmonary embolism. After completion of hydroxychloroquine and steroids, he was successfully extubated 9 days later and was weaned down to 6 liters of oxygen through a nasal cannula. A chest X-ray immediately after extubation showed persistent airspace disease with no other abnormalities. However, 5 days later, the patient's oxygen requirements increased, requiring re-intubation, and CT chest showed a pneumomediastinum as seen in figure number 1. Our second case is a 22-year-old female patient with a history of lupus nephritis who was admitted for hypoxia and also tested positive for SARS-CoV-2. She was intubated within 24 hours of arrival due to severe hypoxia and respiratory distress. 4 days after intubation, she developed subcutaneous emphysema of the chest and neck, with X-ray revealing pneumomediastinum, as seen in figure number 2. Of note, her positive end expiratory pressure had ranged between 12 and 16. Her peak inspiratory pressures have ranged between 18 to 36 centimeters of water, with plateau pressures ranging between 27 and 32. The pneumomediastinum progressed over the following 24 hours. As for our third and last case, this is a 91-year-old male patient who presented from a nursing home with hypoxia and altered mental status. He required 5 liters of oxygen through a nasal cannula on presentation. CT scan on presentation showed ground glass infiltrates. SARS-CoV-2 was detected through a nasopharyngeal swab. He was discharged 5 days later after weaning off oxygen and completing a course of steroids and hydroxychloroquine. He never required intubation. 6 days after discharge, the patient was brought back to the hospital for worsening hypoxia. A chest X-ray on admission showed bilateral airspace opacities suggestive of a multifocal infectious process, in addition to a curvilinear lucency below the aortic knob, consistent with a pneumomediastinum, as you can see in figure number 3. As you know, SARS-CoV-2 is the novel coronavirus responsible for COVID-19. The World Health Organization declared the outbreak a worldwide pandemic on March 11, 2020. SARS-CoV-2 shares 82% of its genome with SARS-CoV, which was responsible for the 2003 outbreak of SARS. During SARS outbreak in 2002 and 2003, cases of spontaneous and secondary pneumomediastinum have been reported, with rates ranging between 7 to 12% in some studies. During our literature review, we found at least 6 different case series and case reports from the US, Italy, and China of patients with COVID-19 whose course was also complicated by pneumomediastinum. While some of these patients were intubated, the rest were never intubated during their hospital stay. Although pneumomediastinum is usually considered a self-limiting condition, our experience suggests that pneumomediastinum may be an under-recognized feature of COVID-19. The mechanism in this disease has not yet been elucidated. However, it is plausible that the brisk inflammatory response seen in this disease may be responsible, causing alveolar damage. In conclusion, it is important to suspect pneumomediastinum as a potential complication of COVID-19, especially when worsening hypoxia is noticed. Further cases of pneumomediastinum in COVID-19 patients need to be reported in order to find a true correlation among these 2 conditions. Thank you for listening. We hope you enjoyed our presentation.